have been overrepresented in terms of COVID-19 cases and subsequent death. It has served as a sharp reminder of health inequities in our society. In fact, the pandemic has removed the veil covering many inequities. Many immigrants infected with COVID-19 have been afraid to seek care for fear of deportation. Let us also remember that many of these immigrants have put their lives at risk, serving as frontline and essential workers, leading the fight against the pandemic. I remember several months ago, the Alvarez family, all of them were infected with the virus. And I'm speaking of three members of that family, and two of them are undocumented. One is fully documented, but none of them went to the hospital to seek care or even get tested for fear of being deported. So the pandemic has pushed many members of our communities farther into poverty, resulting from losing a job and not being able to pay for food and housing. And of course, the digital divide became more apparent during the pandemic. We always knew many communities were being left behind, but during the pandemic, many diverse populations have been left out when much of the activity was moved to a virtual format. And so, as we look to the future and rebuild our communities, it is imperative that we address health inequities and deal with the digital divide by giving our communities access to the virtual world many of us enjoy. We need more employment and training opportunities, especially for older adults who want to continue to remain active in the workforce. So during today's town hall, we're so fortunate to hear from colleagues, friends, and experts on key challenges faced by diverse populations during the pandemic, as well as lessons learned and takeaways from this experience as among African Americans, among American Indians, Asian and Pacific Islanders. Also, we will discuss what we have learned from the pandemic from an LGBT perspective. And so it's important that we keep in mind that many of the diverse populations represented here experience similar challenges, but we have to remember that the solutions to address each community are different. And so it's important that we remain culturally competent when working with each of our communities. We look forward to more collective efforts like this one that improve the lives of older adults, their families, and caregivers. For now, addressing the COVID-19 pandemic and getting our communities vaccinated is urgent. One way we are helping our older adults, their families, and caregivers is through the NHCOA COVID-19 helpline, where we help vaccine registration and provide transportation to the vaccine location. This helpline is an opportunity to inform and empower community members with accurate information and resources to stay healthy and safe during the pandemic. We are working to get timely and reliable information in 3 languages, Spanish, English, and Portuguese. We encourage all of us to visit our social media platforms for more information, or to call the number that's on the screen, 866-488-7379, to be assisted by one of our members. And so we have much work ahead of us. We are making progress, and we remain strong and resilient, hoping for a more equitable future. Before we start, I would like to dedicate a moment of silence for those we have lost during this health crisis, family members, friends, and frontline workers. We appreciate you, and you will always be remembered. Thank you.
Thank you so much, Dr. Cruz, and thank you for the moment of silence as we remember those we have lost to this terrible, terrible virus. And thank you so much for phrasing and framing today's presentation. Our next welcome will come from Ms. Yvette Pena, an accomplished award-winning marketer and community advocate with over 20 years of experience specializing in multicultural initiatives. Named Vice President for Latino Audience Strategy at AARP in 2016, she has led the strategic development of AARP's brand campaigns targeting the Spanish preferred and bilingual segments, resulting in significant brand awareness increases. Yvette champions innovation by leveraging digital, social, and mobile platforms to drive engagements with the 50+ Latinos and their multi-generational families. She builds partnerships with advocacy organizations to drive AARP's social impact agenda with a focus on the Black and Brown communities. She develops and manages relevant offerings and programs for AARP's members in the US and Puerto Rico, with the goal of increasing brand affinity to better serve the Latino community. Welcome, Ms. Pena.
Thank you so much, Cindy. So happy to be here. And hola, everyone, and welcome. As Cindy mentioned, I am Yvette Pena, Vice President of the Hispanic Latino Audience Strategy in the Office of Diversity, Equity, and Inclusion at AARP. Thank you so much for being here and joining us today for this important town hall discussion. I want to extend a gracious thank you to Dr. Janira Cruz and the wonderful NHCOA team for organizing this timely event and inviting AARP to sponsor this discussion. AARP has been working to promote the health and well-being of older Americans for more than 60 years, but in all those years, none have been more challenging than 2020. COVID-19 wreaked havoc on our nation in the form of a pandemic and an economic meltdown. But with a July 4th date set by the White House as one of gaining our independence back from the virus, we appear to be moving past the worst moments and are rounding the corner to brighter days, which is why it's a good time now to take a deep breath and assess the many changes that have occurred and the lessons we have learned. In the Hispanic households, being a caregiver is part of the natural circle of life. It's what we do. The latest statistics show that 27% of US Hispanics currently live in multi-generational households, and 21% take the role of a caregiver. While we've always had respect and admiration for those who are caregivers, this past year has taught us just how special they are. The lesson here is that self-care is an important part of being a caregiver, and it's often the most forgotten duty. According to the Harvard Medical, practicing self-care allows us to remain more balanced, focused, and effective, and that benefits everyone. So please remember to take care of yourselves daily. The pandemic also brought out those looking to cash in on your vulnerability. Hackers and scammers are out in full force day and night, sending emails, text messages, and making phone calls that often appear legit about everything from your vaccine to your grandchildren or even a package delivery. And that is why you need to be more vigilant now more than ever when it comes to protecting your privacy, your family, and your finances. Never give out your passwords, credit card numbers, or any personal information. Heightened levels of loneliness and isolation are another byproduct of the pandemic. Rates of psychological distress rose from all adults as the pandemic deepened. According to a Johns Hopkins University survey published in the Journal of the American Medical Association in June, although we are beginning to see the light as more people are vaccinated. It is our loved ones that matter the most in this world, so please give them a call. The lesson learned is that your words of support and ability to listen can make a difference in someone's life, including your own. AARP recently completed an economic survey of over 5,000 working adults and compiled the findings in a new study, How Financial Experiences During the Pandemic Shape the Future Outlook. Although 43% of respondents said that their overall financial situation today is the same as it was before the pandemic, one third, which is 30%, described their situation today as worse. Hispanic respondents, low-income respondents, and women were more likely than their counterparts to feel that they are worse off today than a year ago. And nearly 1 in 4, about 23%, has prematurely dipped into their retirement savings, or they have stopped contributing altogether, jeopardizing their retirement security. The good news is that working adults do expect to tackle their financial issues over the next 12 months, including debt, expenses, retirement savings. And over half of the respondents, 52%, stated that they believe their financial situation will be better. For updated information, I'd love to invite you on COVID-19 to visit aarp.org/coronavirus, and in Spanish, aarp.org/el coronavirus. There is no doubt that this year and next year will be one of transition. And since positivity plays an important role in our well-being, let's set a goal of staying healthy, keeping mentally strong, and getting financially sound. And now it's time to invite our panel of experts to weigh in on their biggest lessons learned from the pandemic, the key moments we experienced, and their recommendations to move forward for a brighter tomorrow. Muchas gracias for your attendance and attention. I wish you all mucha salud, dinero, y amor.
Cindy, are you there? Yvette, can you hear me?
Yes, I can, Janita.
Okay. Cindy, can you hear us?
Hi, Dr. Cruz.
Hi.
Yes, she's having some technical difficulties, but I will continue on her behalf if that's okay.
Wonderful, wonderful. Thank you. Yes.
Sure. Well, thank you, Ms. Peña. Starting this webinar, we will have polls in which we hope you can all participate and provide your answers. Let's start with the first question. We will provide all of you a minute to complete it. So the first poll, it's going to be shortly, says, what has been the most common problem among diverse populations during the pandemic? We will provide all of you a minute to complete it. Perfect. So sharing our poll results mentioned that it has been all of the above, including greater number of people infected with the virus, loss of income to pay for food and housing, and greater death rate. So before welcoming our next speaker, we would like to ask another poll question about the following. Again, we will provide all of you a minute to complete it. So the question is, moving forward, what do diverse populations need? So again, the answer was all of the above, including resource to address health inequities, employment and training opportunities, and access to computers and computer literacy. Thank you. Cindy, are you here with us?
Yes, I am. I'm back. Thank you so much, Christine and Dr. Cruz and our audience. And please forgive my my absence. I was having technical difficulties, and I think it speaks definitely to the rural, urban, and digital divide. We're having broadband issues, and I know we're going to talk about that issue a little bit later. I mean, it impacts all of rural America, and I truly live in a small town in New Mexico. So my sincere apologies for having to exit for a moment. But as we know, the COVID-19 pandemic has brought social and racial injustice and inequity to the forefront of public health and in our country. It has highlighted the fact that health equity is still not a reality, since COVID-19 has unequally affected many racial and ethnic minority groups, putting them more at risk of getting sick and dying from COVID-19. Some examples affecting health equity in communities of color include discrimination, including racism, that can lead to chronic and toxic stress and shapes social and economic factors that put some people from racial and ethnic minority groups at increased risk for COVID-19. Healthcare access and use and occupation. People in racial and ethnic minority groups often work in essential settings such as healthcare facilities, farms, factories, grocery stores, and public transportation, housing, and many others. So please welcome our first speaker, Mr. Denny Chen, the Directing Attorney for Equity Advocacy from Justice and Aging. Mr. Chan is responsible for developing and leading Justice and Aging's strategic initiatives on advancing equity, which aims to center the organization's advocacy strategies and projects on issues directly addressing systemic inequities faced by older adults of color, older women, LGBTQIA2S older adults with disabilities, and older adults who are immigrants or have limited English proficiency. Today, Mr. Chan will speak about key challenges faced by diverse populations during the pandemic. Mr. Chan?
Hi, everyone. Thank you, Cindy, for that very nice introduction and lead up. I've been asked today to speak on a very big topic in 10 minutes, key challenges faced by diverse populations during the pandemic. And so what I hope to do in my 10 minutes is do a really broad overview with a couple of examples of how older adults, particularly older adults of color, have fared during the pandemic. But before I get started with my remarks, I wanted to first give a big thank you to the National Hispanic Council on Aging, Dr. Cruz and her team, for organizing what I think is a really important opportunity. We are very different now than a year ago in terms of where we are in fighting the pandemic. We are also under a new administration. We have new successes in fighting the pandemic. And so this is a really great opportunity for us to take a moment to reflect on what has worked well and what hasn't worked well, and how we can improve policies for older adults of color in the future. Just a quick introduction to who I am and Justice and Aging. I am the new directing attorney of equity advocacy, and Justice and Aging is a national legal organization that is dedicated to fighting senior poverty, and specifically areas of healthcare, economic security, and elder justice. And we are a policy advocacy organization, and I'll talk a little bit more later about our new strategic initiative to advance equity. So my comments and my examples will really focus on what I'm calling the brokenness of our systems for older adults of color. But before I dive into how the systems have been broken, I want to take a moment and say that part of America's COVID story is also related to the story very much of last year that may or may not have been COVID specific. We found ourselves in the middle of racial reckoning about anti-Black police violence. We find ourselves increasingly having to reckon with anti-Asian sentiment, particularly in some cases targeting older adults because of perceived vulnerabilities. So all of those don't fall neatly in the ballpark of COVID and COVID-19. They aren't strictly about the pandemic, but they really are a part of America's story. And I think is really important for us to think about as we think about moving out of the pandemic. How do we continue to use those data points? How do we continue to use that part of our story to ensure that older adults of color, whether they are Black, Latino, Indigenous, AAPI, are best served by policies moving forward? So the first area I wanted to highlight is really around disproportionate illness and death in communities of color. And this was one of the survey questions, have this as a possible answer. Medicare data released by the Centers for Medicare and Medicaid Services shows that among Medicare enrollees of color, so we're looking specifically at older adults or people with disabilities because they're on the Medicare program, who are hospitalized because of COVID-19, that's basically up to 2 times the rate of hospitalizations for white Medicare enrollees. And the statistics are particularly high for Native American, Alaska Native, Black, and Latino Medicare beneficiaries. And even when we go and try to control by class, by whether someone is on Medicaid or not, because Medicaid is an entitlement program, we still see the same disparities. So we know that it's not just about class and access to economic resources. We know that there's something happening behind the scenes with respect to COVID infections and hospitalizations that is specifically tied to the ways in which our system is broken around race. We also saw, in particular for older adults, in congregate settings, for example, in nursing facilities and assisted living, very early on, last January, we saw that there were outbreaks in skilled nursing facilities across the country. And I think one part that got lost in that larger narrative is that for residents or for facilities that serve mostly residents of color, they had even higher rates of COVID-19 infection and death. And so that, a lot of it has to do with community spread in terms of where, workers and employees of the skilled nursing facilities were coming from and bringing the virus in. But we saw that as very much part of the COVID-19 story. So we already saw off the bat, as people were getting sick and dying, that there was disproportionate illness and death in communities of color, and that specifically for congregate settings, those rates were even higher when they were serving primarily residents of color. Not to even mention the pre sort of COVID-19 reality that most of those older adults probably don't want to be in the facility to begin with. Another area where we saw kind of the system breaking down was how broken our medical system is, our public health system. And here I want to give one example. There's a lot about access to testing that early on, tests were not available to many different communities. There was a lot of advocacy around testing deserts where people could not get a test even if they wanted to. And you can imagine that there was significant overlap in communities of color in those testing deserts. But the thing I wanted to pull up is specifically around another sort of lesser known issue, which is this topic of crisis standards of care. Crisis standards of care are basically policies where public health hospitals and health systems use when there are not enough medical resources. So basically it helps answer the question, who gets that last hospital bed or who gets that last ventilator, knowing that we're going to run out and we have to make some hard decisions. And what we saw in crisis standards of care in 2020, so just last year, was that these policies actually wrote age discrimination into the policies themselves. So for example, they would say, if there's a tie, for example, there's a very elaborate scoring mechanism. And if there's a tie between two patients, then we're going to give preference to individuals who are younger than 65. And when they wrote this policy and when they released these policies, oftentimes they would include language justifying why this was an appropriate policy choice. Their justification or their rationale was that most people think that the ventilator or the hospital bed should go to the younger person because they have yet to live out their full life cycle. So in other words, these policies used ageist beliefs, commonly held ageist beliefs, to actually write ageism into the policies and justify it in that way. Obviously, this has a significant impact on older adults who were already sheltering in place and didn't know if they, should be going to a hospital. The reality was that some policies existed out there that said that they wouldn't get the hospital bed or wouldn't get the ventilator, or at least they would receive less preferential treatment simply because of their age. And if you look specifically at how these policies often handled intersectionality, this idea that there are older adults with multiple identities, what we saw was even worse, that for older adults of color, the way these policies worked is that it often scored you based on a very complicated formula, as I said. And one of the factors is your life expectancy. We know that particularly for Black older adults, they have a lower life expectancy. So again, you saw in print, baked right into the policy itself, a discriminatory, and in this case, discriminatory on the basis of age and race, specifically that intersection of those two, right into the policy as recent as last year. A number of federal civil rights complaints were filed about policies across the country. We at Justice and Aging worked pretty tirelessly to make sure that these discriminatory policies were not implemented. But it shows you that people's commonly held beliefs, whether they are racist or ageist, often end up in policy even as recent as last year in trying to battle a global pandemic. The other thing I'll say about the scarce medical resources and how broken the public health system was, is that we also saw some significant stories about limited English proficient older adults, whether they're Spanish speakers or other speakers of other languages, that in the chaotic environment of all these people going to the hospital and needing scarce resources, there oftentimes was not a priority for them to receive interpretation, things that they would need to be able to meaningfully access services. And then we also have seen now, several months out of our most traumatic wave thus far, that LEP older adults were more likely to die from COVID-19. That has been established in the medical research. And all of that, I think, has a lot to do with the fact that we set up a testing system, we set up a medical system without older adults in mind. And so you would think that as we were planning for the distribution and access to vaccines, life-saving treatment, that we would have had a different approach. But unfortunately, those similar dynamics existed even as we began the vaccine rollout. So despite months of planning, we were not prepared. And despite the fact that we know older adults and older adults of color, LEP older adults, exist in our communities, are members of our families, policymakers and those who unveiled the initial COVID-19 vaccine efforts really didn't account for them. And the ironic thing was that across most states, in fact, I believe across all states, older adults, individuals, whether it was 75 and up or 65 and up, were prioritized. In other words, they had initial access to the vaccine as early as January of this year. But again, what we saw was that that prioritization was rendered meaningless because oftentimes people face practical challenges getting the vaccine. Number one, there were issues signing up for a vaccine, whether people have already alluded to the digital divide. So whether you had access to technology, whether you felt comfortable using that technology, whether any of the registration process was in your language you could understand. A number of public health departments use Google Translate, unfortunately, and we know the ways in which Google Translate is inadequate for these communities. In addition, what we saw was problems actually getting to the vaccination center. Would you have the transportation? If you are an older adult who stays at home and has mobility challenges, can you get the vaccine at home? All these questions, of course, we know were important policy questions, but were not answered prior to the vaccine being made publicly available. Of course, we also have an ongoing issue of vaccine confidence. People talk a lot about Tuskegee, but we also know that people have lived real experiences of medical racism that fuel their distrust or mistrust of the medical providers. And in addition, I believe Dr. Cruz mentioned at the beginning, we began a mass vaccination effort across the country after a previous administration had spent 4 years attacking immigrants and making immigrants much less inclined to trust public sources. So you can imagine some of the challenges, whether it's people's lived experiences of racism with the medical system or some distrust they would have about getting a shot from government because government has not been friendly to who they are based on their immigration status. All those posed real challenges as we were trying to fight the pandemic in that last wave. And then I'll also say, as a quick example to wrap up the issue of vaccines, is that even in California, where I'm based, we continue to not have a statewide policy for people who want to get the vaccine at home. It largely depends on what county you live in, what the public health department has available, and particularly when we had paused the Johnson & Johnson vaccine, that was not a helpful development, and now it's back on again. So it goes to show you that even several months after the vaccine was technically available to you as an older adult beginning in January, that you might still be waiting today to get that vaccine at home because of a system we've set up that doesn't account for who you are and how you need to get your care. I'll make a quick note too, before I jump into recommendations about, all these are ways in which the system was broken. The other thing that we have to be thinking about as we think about coming out of the pandemic is that we've also been asking older adults to largely shelter in place because of the risk that COVID-19 that the COVID-19 is to their health. That has an intangible, emotional and physical toll on the lives of older adults. And as a personal example, I'll give you, my own grandmother had been sheltered in place very seriously for much of the pandemic, and so much so that toward the end of it, or toward the end of last year, when she went to go outside of her apartment building or apartment unit, she realized she had forgotten how to use the elevator. And these are things that happen with older adults, but certainly staying at home for multiple months on end and not doing regular things that you would normally do as part of your day make that recovery much harder. So if I can take a minute now and talk a little bit about recommendations before I pass it along to other speakers, what I want to say is that we have a real opportunity here. We have a real opportunity to improve systems. And there seems to be across the board, whether it's the new administration or advocates, a real deep desire to dig into our systems and improve them for the future, not just for the next pandemic, not just to get out of this pandemic, but a real wake-up moment to say what we had before. COVID has shown us how broken it was. We all kind of knew it was broken, and COVID really just shut the whole thing down. So here I would like to make 4 kind of overarching recommendations. One is that we need to continue focusing on policies that support older adults of color. We continue to believe that by supporting older adults of color, we support many older adults, and specifically many low-income older adults. We at Justice and Aging, as I mentioned before, launched last month a new strategic initiative to advance equity. And that has a primary focus on advancing race equity for older adults of color. We will continue doing that work and continuing to champion policies that really lift up and address the concerns of older adults of color. And in particular, some other recommendations would be, 1, to improve the home and community-based system of care. We have in our country and in our healthcare system a severe reliance on institutional care, that is getting care at home at a facility, in a nursing facility or at an assisted living facility. And unfortunately, what that means is that we don't have enough options for people to get care where they need it. So President Biden announced $400 billion for direct care. We'd love to see that in communities of color. 2 more recommendations before I turn it back over. One is that we want to make sure there are more robust anti-discrimination requirements. The previous federal administration rolled a lot of those back, and we need to make sure that there are more teeth in those requirements to continue to attack discriminatory policies. And the last recommendation is really around data. We have very little data. It's not centralized, it's not standardized, and it was not available in real time during the pandemic. The White House Task Force on Health Inequities is looking at this issue, and we believe this is a real opportunity to build a data system into the future that reflects both the advanced technology that we have in our country, and one that really will account for and allow us to measure health inequities and disparities moving into the future for older adults. So I know that my time is up, and I will turn things back to Cindy. Thank you so much.
Thank you so much, Denny. And wow, yes, and you started off your presentation telling us you had a lot to tell us in a short amount of time, and it's just so true. But thank you for ending with opportunities, and hopefully we can take the recommendations and as advocates move those forward. I just want to let you all know that if you have any questions for any of our presenters, please use the Q&A function that you see at the bottom of your screen. There's a little comment box that says Q&A. You can type your questions in there, and we'll get to those as soon as we possibly can, when we get to the end of the session. And hopefully we'll have adequate time to answer some of those questions, as we have so much information. American Indian and Alaska Native persons experienced disproportionate mortality during the 2009 influenza, the H1N1 pandemic. And a recent analysis from the Kaiser Family Foundation indicated that the COVID-19 pandemic has also disproportionately affected American Indians and Alaska Native people. Reflecting on these increased risks, American Indian and Alaska Natives people are nearly twice as likely to be infected with the virus, nearly 4 times as likely to be hospitalized, and nearly 2.5 times as likely to die due to COVID as their white counterparts. So now let's hear from our next speaker, Rebecca Owl Morgan, Project Coordinator at the National Indian Council on Aging, or NHCOA. She is an enrolled member of the Eastern Band of Cherokee Indians located in the Great Smoky Mountains of North Carolina. She has degrees in history and library science. Her work at NHCOA has highlighted the strengths and proud history of Native people and the helpful tools elders can use to become powerful self-advocates for themselves and their tribes. Ms. Morgan will speak about lessons learned from the pandemic among American Indian and Alaska Natives. Ms. Morgan?
Hi there, Cindy. And I didn't know there was another person from New Mexico. So hello, we're neighbors. I'm in Albuquerque. So
Good to see
glad to meet you. And again, Dr. Cruz and all of the National Hispanic Council on Aging, thank you so much for allowing us to join you on this panel today. It's going to be a very vigorous and lively discussion, as Mr. Chan's already got us off to a great start. We always, when we meet together, have to say we're NHCOA with an I to try to differentiate ourselves. Could you go to the next slide, please? So the mission of NHCOA is to advocate for improved comprehensive health, social services, and economic well-being for American Indian and Alaska Native elders. We're a membership organization established in 1976, and the theme for our first conference was the Forgotten American. That remains an ongoing challenge. NHCOA operates a job training program, the Senior Community Service Employment Program, CSEP, funded by the Department of Labor. We have grants funded by the Administration for Community Living, Administration on Aging, including the Older Adults Equity Collaborative and the Tribal Long-Term Services and Supports Project. And then the Diverse Elders Coalition and the John A. Hartford Foundation fund a project that we're part of, focusing on the needs of diverse family caregivers. We host an elders conference, and the next one is planned in August for Reno, Nevada. Next slide. I thought it would be helpful. We did a needs assessment, and I wanted to share some of the comments. Out of respect, these are all anonymous. My family has used an herb that strengthens your immune system. My family believed that it would lessen the effects of COVID, so it wouldn't be so bad if you ever got it. Tremendous losses for community tribal elders, spiritual leaders, first language speakers. Fear among elders, sadness of not being with family, cannot be with loved ones in long-term care facilities. Working in the only Native American nursing home in my state, we have had to test our elders and staff frequently, and it's taken its toll on both. We strive to help support our elders in this time of isolation, but it's very hard watching them spiral down without being able to engage in the social interaction they were used to. My own family is scared to contract the virus, as being out of work will only make the depression worse with no money coming in. Trying to find a life between trying to be safe and live a normal life is very difficult and stressful. Even though my husband and I were very careful because we have health problems, we both contracted COVID-19. Very sick, we got through it within 2 to 3 weeks. We both work with elders at the tribe. Seeing what they're going through is most difficult. Not being able to see them, not having our health fairs, coming to the tribe to exercise, and not having monthly support groups, birthday parties, etc. We're doing what we can to keep in contact and supporting them as much as possible. Not being able to go to powwows, no concerts, not traveling anywhere. Lost family interaction, no work, but went back to college. Lost 2 Vietnam veterans to COVID-19. I'm an artist in my spare time. I lost my creativity and lost my ability to sell in my community. This has affected many small home businesses that count on supplementing their income with jewelry and handcrafted sales. Our tribe has always been supportive of having vendors in our tribe and community offices, but that's stopped since the beginning. And no powwows, indoor or outdoor this year. This has affected us dramatically. Next slide. Some statistics about COVID in Indian country. 5,981 deaths in Indian country have happened during the pandemic. And this is the most recent data as of March 17th, 2021, according to the National Indian Health Board. 3,589 of those who died were elder Indians, are an estimated 60% of total deaths. Of the total number of deaths in Indian country, 59.2% occurred in 2 states, Arizona and New Mexico. Next slide, please. I think one of the differences that's unique about Indians and Alaska Natives is their relationship with the federal government through the IHS. And I wanted to take a moment to explain that a little bit. The Indian Health Service, or IHS, is an agency within the Department of Health and Human Services. IHS is responsible for funding federal health services to American Indian and Alaska Natives. The provision of health services to members of federally recognized tribes grew out of a special government-to-government relationship between the federal government and Indian tribes. And this relationship was established in 1787 in the U.S. Constitution. Health services are provided directly by IHS through tribally contracted and operated health programs and through services purchased from private providers. The federal system consists of 28 hospitals all over the country, 59 health centers, and 32 health stations. In addition, there are 33 urban Indian health projects. Excuse me. And then through the Public Law 39-638 self-determination contracts, American Indian tribes and Alaska Native corporations administer 19 hospitals, 284 health centers, 79 health stations, and 163 Alaska Village clinics. This is a screenshot is taken from the IHS webpage, and it shows the positive cases by IHS area. There are 12 areas, and as you can see, Oklahoma City region is darkest and has the largest recorded numbers of cases when the map was last updated. Next slide, please. Another important source of information, reliable information, is tribal epidemiology centers. And again, as we had the 12 regions for IHS, there are 12 tribal epidemiology centers across the country. They work with local and area tribes to improve health and well-being for tribal community members and offer culturally competent approaches that work towards eliminating health disparities that are faced by IAN populations. They have been doing lots of on-the-ground work during the COVID crisis. And they have been so helpful to NHCOA and many other organizations in terms of research and other important areas, radon, for example. But we're talking about COVID today. So they work with tribes, the IHS, and other agencies throughout the country. Next slide, please. The National Indian Health Board, or NIHB, represents tribal governments, both those that operate their own healthcare delivery systems through contracting and compacting, and those that receive healthcare directly through the Indian Health Service. They're located in Washington, and they're a nonprofit that provides lots of different services to tribes, area health boards, tribal organizations, federal agencies, and foundations. They do advocacy, they do policy formation. They have so much information about COVID. They have a whole page dedicated to lots of information that's helpful for all kinds of groups and all sorts of interests. And I also need to say that we at NHCOA have our own COVID webpage, but we rely greatly on these other sources of information to find out where things are and how they stand with COVID during the crisis. Next slide, please. In terms of lessons learned, here's some observations. And I worked with our executive director, Larry Curley. So some of these are his observations. He was called to another meeting and regrets he couldn't be with you, but he's shared this with me to share with you. Tribes have exercised their sovereign authority to separate from state actions regarding their response to the pandemic. So they've closed down their borders at the beginning to help protect their communities, and that was very important. They declared emergency orders early, and they innovated service delivery as quickly as possible. They did things like address social isolation with car bingo. They would have a drive-in and large parking lots. All the little baggies with the cards and the markers were sanitized, and people would run the bags out to the cars, and people would call the numbers with a microphone. So it was a pretty creative solution. Tribal elders during this time were prioritized for vaccines due to their knowledge of tribal culture and language. So there was a strong collective spirit that was sustained the communities across the country. Some other things that were creative were the colored paper project. So on the picture on the left, you see the Wabanaki Public Health Department in Maine wanted to monitor the needs of their isolated elders. And so they just gave them some colored paper, and they would put that in the window to indicate how they were doing. They would put red in there if they displayed that if they needed medical help, yellow if they needed supplies, blue if they wanted a friendly ear, and green if everything was okay. In the next picture, you see the sweat lodge guidance, and that one really, I thought that was exactly what was needed. This is from Tuba City Regional Healthcare in Arizona. They have 30% of their funding that comes from IHS, and the rest is from third-party payers and grants. They started a nurse hotline, virtual visits for people that were more ill. And then they did public health messages tailored to their members, like how to hold a ceremony safely and how to take part in sweat lodges in a way that was safe. A woman was on the staff said, "We're not trying to make them do things they don't want to do. We're trying to be helpful and keep our families safe." Then also in the Pueblo of Acoma in New Mexico, they took a lot of early measures to deter outsiders from visiting. They did universal testing to isolate infections and hotspots. They did orders for social distancing and masks. And with their healthcare, they did strategies such as telehealth, partnered with a firm that helped them to identify early cases of COVID. And they shared medical data with mobile and wearable devices for trend analysis through HIPAA compliant clouds, which not everyone is possible to implement, but I think that was very foresighted of them. And their cases were 12% less than the surrounding county. In terms of urban programs, the Seattle Indian Health Board in Washington State offers primary care services, traditional healing consultations, and drum circles. And they instituted a telemedicine kiosk that people that didn't have access to a phone or a computer could go and talk to a doctor, and they would sanitize that between visits. The Mississippi Band of Choctaw Indians partnered with IHS with a critical response team, and that was really helpful in terms of getting everyone mobilized. In Gallup, New Mexico, a border town near Navajo Nation, the local IHS partnered with another local hospital and converted hotels into temporary respiratory shelters. The next slide. Ricardo Cate is a wonderful national treasure, in my opinion, and he does cartoons, and this one is a public health message. As you can see, the smoke signal looks like the coronavirus. And then the next slide is another example of his work. The native person washing his hands, talking to a raccoon, and says, "What? You didn't think you were the only one obsessed with hand washing?" So I think this kind of light touch and humor is very effective in our Native communities. Next slide. So looking ahead, the idea here is that now that we've gotten mobilized for COVID, that we have to prepare for the next pandemic or emergency. And because of this, we want to ensure our elders are safe. And the services that have been designed need to respond to changes in the flexibility. So tribal sovereignty was really key in terms of being able to respond quickly. And as Cindy was mentioning earlier, the numbers according to that Kaiser Family Foundation report show that 32% of American Indian and Alaska Native people have received at least one dose of a COVID vaccine. I would like to share something from an article that Larry Curley wrote in Next Avenue. It's a wonderful reflection. It's called An American Indian Reflection on COVID-19. And within it, he talks about the optimism and the resilience of Native peoples. Mm-hmm. And he offers a traditional blessing. I'm not Navajo, but I hope this blessing is heard by the Creator. With beauty before me I walk, with beauty behind me I walk, with beauty above me I walk, with beauty around me I walk. It has become beauty again. 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 Thank you. The next slides are the references and my thanks.
Thank you so much, Rebecca, and thank you for ending on that note. I mean, I think is so important for us and to completely understand the resiliency and the strength of our Native people. And being in New Mexico, we definitely need to get together at some point. We're not that far apart, but thank you so much for sharing that. So before we get to our next panelists, we would like to offer a couple of more polls, and we're doing the polls really to get a sense from our audience, from all of you, your thoughts as well as we present the information today, but also based on your own experience. So the next question is, did the pandemic highlight the importance of our mental health? You have answer number one. I think I need to go to the next slide or the poll. Answer number one is yes, and answer number two is no. So again, the question, did the pandemic highlight the importance of our mental health? I know that you all are looking at that, and and we could move to the results of our quick poll. Are we seeing the results? So an overwhelmingly 97% of you have said yes, that it did highlight, and 1% or one answer says that no, it did not. The next question is, has the pandemic revealed health inequities among Black and Brown communities and communities of color? Again, first answer is yes, second answer is no. Again, an overwhelmingly large percentage of you have saying yes, it has revealed. I think it's shown the light. A couple of our participants have said no, that it did not, and perhaps it's because we knew that these inequities existed all along. So thank you for participating in that poll. According to the CDC, the longstanding systemic, social, economic, and environmental inequities in the United States have put many communities of color, racial and ethnic minority groups at increased risk for exposure to and infection with the SARS-CoV-2, or the virus that causes COVID-19, as well as more severe COVID-19 related outcomes. African Americans, compared with all other racial ethnic groups, are more likely to contract coronavirus disease, be hospitalized for it, and die of the disease. Psychosocial, sociocultural, and environmental vulnerabilities, compounded by pre-existing health conditions, exacerbate this health disparity. However, the availability of the vaccine is one of the most effective tools in our toolbox to protect our health and prevent or minimize severe complications if contracting the virus. Our next speaker, Ms. Karen Jones, President and Chief Executive Officer of the National Caucus and Center on Black Aging, or the NCBA, based in Washington, D.C. The NCBA is the largest minority-focused aging organization recognized as the leader in senior housing, employment, health, and advocacy on behalf of minority seniors. Ms. Jones will speak about lessons and takeaways from COVID among African Americans. Welcome, Karen.
Haven't learned yet how to unmute on time. Listen, thank you so much, Cindy and Yanetta and everyone from NCOA, National Hispanic Council on Aging. This is my fourth Zoom today, so please, if I'm a little giddy, it's only because I'm almost just kind of worn out. And I've got one more tonight at 10 o'clock because it's in California. So, You know, it's been so interesting during this pandemic because, of course, in the African American community, we have always said that when America catches cold, African Americans get pneumonia. And certainly COVID-19 has proven to be another devastating impact on our community. This is a quote that I made some time ago that ran, I am a part of a convening, which I'll talk about in a minute. And I know we're running very short of time, so I'm going to go very, very quickly. If you just go to the next slide. And I'll just briefly, Denny really talked about a lot of those things, but I can just tell you that we don't, particularly not only from Johns Hopkins, but from other resources that in the African American community, we know that living in crowded housing, being essential workers, obviously having no insurance or being underinsured, and access to quality healthcare, our usual health inequities in terms of chronic health conditions. And we've just been through a year of major stress dealing with racism, police brutality, and that creates, which we're very proud, we're not proud, but we're very happy to see that the CDC has named racism a major public a health condition that we have to do. And so that in itself has lowered our immunity, all of these factors. And we've known about these factors. It has been highlighted even more so during COVID-19. Next slide, please. Everybody focuses on the Tuskegee project because it's probably the most well-known in recent years, but the history of medical experimentation on African Americans goes all the way back to when this country began. If you have had a cesarean birth, you thank a slave woman, slave women, I should say, because that practice to make sure that that was a safe way to deliver children was done on slave women with no anesthesia to figure out how to do it. I can name all kinds of things. There's a book out now called Medical Apartheid that explains all of the medical experimentation that went on African Americans. Obviously, that has been handed down and we're quite aware of it. So you can understand our hesitancy, the misinformation that we get in terms of our healthcare. We obviously continue to have a lack of access to quality healthcare, both from the implicit and explicit bias in treating us, the lack of treating our pain or taking our pain as seriously as they may others. Again, the misinformation, the conspiracy theories that are out there. When this pandemic began, we had to try to dispel some of the theories that 5G caused coronavirus. That one was rampant for a while. Another one is that the mentality or the, I don't want to get political, but that the national leadership at the time had spent an entire 4 years being very discriminatory and racist. And so they felt like this was something that people were going to try to inject in our bodies to, if not kill us, certainly as a way to track us. I mean, we had all kinds of conspiracy theories that going on that we had to try to dispel. Again, lack of trust in the national leadership. That was, well, I won't even go into that. And then just basic mistrust. The vaccine, we all know that there's a long process to developing medications and vaccines. And this one was going to be done within a year. And so there was some concern about the rapidity of the process. Next slide, please. So, our early efforts were to address those concerns in our African American population. Obviously, we deal mostly with African American seniors, but their families were a big part of this because so many within family members were affected. We obviously with loss of jobs, illnesses, deaths, just the entire fear that was out there. So we really tried to address those concerns because we knew that when the vaccine became available, we needed as many people as possible to trust that this is what they needed to do in order for us to, number one, eliminate the cause of death for so many people, but also to get back to some kind of normal life. So we solicited support from all of our trusted voices. Our trusted voices in our community, as you well know, are our ministers, our teachers, not necessarily celebrities, though some of them are effective, but or our public officials even, but people within the community that people trusted in terms of, if they say that it's okay, then I'm going to really listen and try to empower myself to understand why it's important for me to get this vaccine. We early on had to address the appointment process, obviously because of lack of internet access or just the inability to try to get an appointment became a real hassle. And so after even dealing with the testing, then we had to immediately start on vaccine access. So these were immediate things. It was like one thing happened after another. And there we were still trying to deal with some hesitancy, but even if they got people to say they were going to take the vaccine, it wasn't available to them. It was not accessible. And really and truly, there was a strong feeling that they put out the conversation that in our community, there was so much hesitancy, and we feel that maybe the rollout was a little slower to get into communities of color because they assume, well, if the demand isn't there, let's not waste sending vaccines there. Let's send it to where we know people want to take it, because it did have a short shelf life. And so we feel that that might have been another part of some of that explicit bias in how you treat communities of color. So if you don't put it where people can have access to it because you want to put out the perception that there's this hesitancy and that nobody's going to take it, then obviously then we fall behind the 8 ball again. So we really had to address testing sites and vaccine sites so that people would have access to those things. And again, we work very closely with community groups, civic groups, religious organizations, churches, Masons, fraternities, all of our usual network in getting information out and working together in partnerships in our communities. And these things are still a work in progress. There's no way that any of these things stop. We continue to try to address. Now our biggest thing is working in some of the rural areas. We've, I think, done a very good job of getting the information and access done in urban areas. I heard the mayor of New York saying that and also the president last night saying that within 5 miles of anybody's home, you can get the vaccine. Well, that's not the case in rural areas. And so we're working very hard on that one. Next slide, please. Next slide. So early on, NCBA joined with the Alliance for Aging Research and Healthy Women, and we convened to talk about how we could address, not to tell people they ought to take the vaccine, but to educate people so that they understood why it was important for them to get the vaccine, and then they feel empowered to want to do that themselves. Since that time, since we convened, we've been able to get over 200 of our partner organizations to be a part of it, which includes the National Council on Aging, Justice and Aging, all of the NHCOA, all of the groups that are part of this are now part of our Project 19 Vaccine Education and Equity Project. And through the working in this partnership, we've been able to reach so many different networks far beyond our own to be able to really educate people, give them the information so that we can address that hesitancy and get more people. And so we're seeing a real decrease in the hesitancy until the Johnson & Johnson thing happened, and then that kind of made it surge back up. So we're back to working on some of that, but people understand, I think, that we're ready to get back to a normal life, as they put it. We also have a website called the Count Me In campaign, which means that if you want to tell your story on why you got the vaccine, it's so important because you don't realize how you individually or people that you know individually, once they tell their story on, well, I got the vaccine because I want to be able to go hug my grandmother. Well, I got the vaccine because I'm a teacher and I want to go back to work. All different reasons. Next slide, please. So very quickly, our lessons learned from the process that we've been through over the last year is that it is so important that we provide information that is specific to communities of color. And so we wanted to work on those efforts. Everything cannot happen through the internet. Remember, libraries were closed, so that was usually an access for some older people to get onto the internet. They were closed, so it was really very difficult. So we definitely wanted to make sure that we improved our way to address specific communities of color and get information out to them. One of the things early on is I don't think they gave enough information and empowered physicians who people primarily depend upon for their health information. And so we want to make sure that doctors then are able to reach out and get the information. I mean, they should have been some of the first to be able to get the vaccine, to be able to distribute it. So, there are other things that we think we would change, and we've learned from this process that, we should really look out and to be able to outreach the patients. Again, ensure that testing and vaccine sites are accessible in all communities. Do not make these assumptions that, well, they're not going to want it, so let's not send it there, or don't worry about it, nobody's going to go over that way. We have to make it as accessible as possible. And if you think this is the last pandemic that we're going to face, it is not. So we have to be prepared, and hopefully things that we've learned from this last time we'll be better prepared to deal with organizing and getting the information out there. And then, of course, an ongoing thing, which we've all been doing over many, many years, decades even, but really has been brought to light, is to continue to address healthcare disparities and the inequities in this country. That's what creates distrust. That's what creates the hesitancy, because people know that they are not treated fairly. They're not treated in any equitable way, and healthcare is not as accessible to them. The president himself said last night that healthcare is a right, not a privilege, and we have got to continue to say that over and over again, because that's the only way we'll be able to deal with this kind of pandemic or just healthcare in general. A healthy society is a productive society. And why people don't believe that they want everybody to be healthy so that we can be the most productive society in the world is still beyond me, but we've got to continue to work together and make that difference. Next slide, please. So thank you very much. If you want more information, there's our website, and then the COVID-19 Vaccine Education and Equity Project. You really can get a lot of information on there about the process. And so I'd encourage you to go on there. And thank you again very much for including me in this panel.
No, I'm the slow on the mute. Sorry about that. So thank you so much, Karen. We really appreciate it. And as you can tell, there's just so much information as we talk about all of our diverse populations in the United States. And I just want to put a little note on time. We are scheduled to go for another 15 minutes. And we have two speakers remaining that have just still an incredible amount of information. And so we're certainly hoping that you all can stay with us until the end of our presentation. Again, we're being recorded, will be on our website as well as our YouTube channel, and just so much information, but all of our diverse populations, working together. So again, we hope that you all can stay with us until the end of the program. So we do have our next question, and just to get a sense from all of you, your feeling about has the vaccine rollout equitably served diverse populations? Answer number 1, yes. Answer number 2, no. so we can take a look at our answers, get a sense from our viewers and our participants. If you all think that the vaccine rollout has equitably served diverse populations, overwhelmingly, we have 83% of our viewers are saying no, it has not. And a few percentages have said yes. So thank you for your input. But it is a fact in the US that the burden of mortality and morbidity has fallen on minority populations. And although there is limited understanding of the impact of this pandemic among Asian Americans and Pacific Islanders, disaggregated data suggests disproportionately high mortality rates. Asian American and Pacific Islanders are at high risk for COVID-19 transmission, in part due to their overrepresentation in the essential workforce, but also due to a high comorbidity burden, which may increase their susceptibility to more severe COVID-19 infection. Furthermore, Asian American and Pacific Islanders have encountered rising xenophobia and racism across the country, and we fear such discrimination only serves to exacerbate these rapidly emerging disparities in this community. So now we're going to hear more from our next speaker, Ms. Kuen Din, the Executive Director of the Southeast Asia Resource Action Center. This center represents the largest refugee community ever resettled in America as a civil rights organization and works to empower Cambodian, Laotian, and Vietnamese American communities to create a socially just and equitable society through policy advocacy, capacity building, community engagement, and mobilization. As Executive Director, Ms. Din is a leading voice for Southeast Asian Americans on key civil rights issues, including education, immigration, criminal justice, health, and aging. Today, Ms. Din will speak about what we have learned from the pandemic and Asian and Pacific Islander perspective. Welcome, Ms. Din. Thank you for being with us.
Hi, everyone. Thank you, Cindy, for the introduction and the context for the AAPI community. It is such an honor to be here. And as Becky, as Denny, as Karen were speaking, I kept nodding and nodding and nodding because the challenges that our communities have been facing under this pandemic have just been too similar. And for us at CRAC, to give a little bit of context for Southeast Asian American communities, we are part of the larger Asian American Pacific Islander community, which in the most recent data analysis of US Census between 2000 and 2019, this data revealed that AAPI communities were the fastest growing racial and ethnic communities to have grown within 2000 and 2019 at a rate of 81%, followed closely by the Latinx community at 70%. Our communities are comprised of over 50 ethnic communities, and CRAC's communities, as Cindy mentioned, are part of the newest wave of immigrants and refugees to our country. And just to give folks a little bit of background about our communities, one of the legacies of CRAC's founders was the passage of the 1980 Refugee Act, which led to over 1 million refugees being able to call America home from the biggest refugee crisis that the world had ever seen, coming from Vietnam, Cambodia, and Laos, including folks like my parents who risked their lives not knowing if they would live or die so that today I could be free. So I hold that mission to my heart dearly every day as I do this work to advocate on behalf of our communities. And if we go to the next slide, just to give a little bit of context for CRAC's communities, we define Southeast Asian American at CRAC as political identity from those who have the shared experiences of fleeing their home countries as refugees, but also experiencing the same challenges of poverty and acculturation when we were able to come here to the US. Today, our communities number over 2 million. And if we go to the next slide, what we see at CRAC is our duty and our responsibility to really protect the key rights of our communities. in creating social justice and creating an equitable society, including protecting 3 core rights. That is the right to family through immigration policies that unite us rather than deport us, through health policies that address the intergenerational traumas of war, of genocide, of displacement, and also the right to be seen through disaggregated data in the education system, but really throughout all of our most important social determinants of health. And if we go to the next slide, the remarks that I wanted to share in terms of what we've learned on this pandemic include 3 major themes. One is the exposure of the longstanding inequities that were revealed during the pandemic. The second was the response that communities had nationwide that really demonstrated the resilience of our families and communities despite broken networks. And finally, the real need to repair broken systems, as we have heard so clearly from all of our speakers before. So if we go to the next slide, I'll start with the main theme of exposure. And that is what folks have already shared in their analysis, is that the pandemic really revealed longstanding health inequities and socioeconomic inequities that have existed for decades. For Southeast Asian American communities, we know that our communities, by and large, have higher rates of women's English proficiency compared to the average American public. And we also experience higher rates of poverty. This has resulted in higher rates of post-traumatic stress disorder, especially as survivors of war and genocide, including, for example, over 60% of the Cambodian community who experiences post-traumatic stress disorder from being survivors of war and genocide, compared to just 3% of the US population. Under the pandemic, we saw that these challenges were exacerbated. We found that first and foremost that folks were trying to make ends meet. Layoffs were huge. As Cindy shared, the biggest sector of employers for the Southeast Asian American community is the service industry, which were the first to be shut down under the pandemic. And with that came challenges to pay for housing, to put food on the table. And at the same time, the digital divide was impacting everyone, from elders to young people who were now shifted to completely remote education, and also increased fears around ICE detention and deportation under the Trump administration. And one data point that we didn't share on the slide was the increased rates of mental health strife and trauma, particularly for our elders, as folks were experiencing more isolation from not being able to engage in their regular social networking activities and events. And if we go to the next slide, one of the issues that have already been talked about was also the escalation of racism that was being targeted at Asian American communities at large, stemming from the Trump administration's framing of the disease as the China disease. And what we saw from organizations such as Stop the API Hate, who developed an online hate tracker or hate crime and incidents tracker, found that of the incidents that were reported, seniors age 60 and older were about 6% of total incidents. And we do know that this reporting is also underreported in and of itself, as so many of our community members don't even know that they are able to report incidences of violence or hate or assault. And yet, with the data that we do have, this is more data than has ever been revealed before as it relates to the rise of API violence across the country. And one last thing I'll note is that while these challenges were being exacerbated, what we also knew was that the lack of disaggregated data about Asian American civic under communities, meaning how were different ethnic communities being impacted by COVID, was actually also continuing to exacerbate the problem. Early on in media coverage of COVID, there was lots of narratives about Asian American communities experiencing or contracting COVID at less rates. But in fact, we knew from our own lived experiences and from working with our communities that because of our socioeconomic status, as well as standing chronic health issues, that our communities were more vulnerable, similar to other communities of color, other low-income immigrant Native communities. And in areas where we did have disaggregated data, including Santa Clara County, we saw, for example, that the Vietnamese community had overwhelmingly larger rates of contraction compared to the general Asian American community. And in Long Beach, there was similar data that was revealed about the Cambodian community. For CREC in our communities, we certainly saw the effects of the pandemic and really expanding these challenges that had already persisted in our communities. And if we go to the next slide, one of our lessons learned from the pandemic is that our communities are incredibly resilient. And you've heard that through the remarks from all of our speakers before. But I think in taking a step back, what we saw across the country were organizations who first and foremost made sure that the safety of their teams, their organizations, and their communities were first priority, including shutting down, going to remote work. And from there, the second priority was really understanding what the community needs were. We did a survey of over 40 organizations across the country, and those organizations themselves also conducted a lot of research by phone banking all of their clients to find out what were the emerging needs within the community. And from there, we saw an incredible response, as Becky shared, innovation from mutual aid of folks being able to shift their funding to provide support for housing, to pay rent, to help pay for food, to do food delivery. We saw a shift to virtual programming, including telehealth, including wellness checks for our elders in particular. And we saw that organizations also tied these new approaches with the advocacy that was so important in 2020, including reminding folks to respond to the US Census to make sure that our communities were really seen and heard, and also to use their phone banking systems to do voter education and voter registration as part of the 2020 elections too. And finally, organizations set up ways to report hate crimes, similar to Stop API Hate. And we also found opportunities to advocate for the longstanding issues that we've seen so far around lack of visibility, lack of access for individuals because of the immigration status, and continued attacks to our communities because of deportation, by advocating on these issues during the conversations around COVID relief and the CARES Act. And if we go to the next slide, I'll wrap up by just sharing that the final lesson learned for us is that the pandemic taught us about the essential need to really focus on long-term repair of these systems that have always failed our communities. And first and foremost, at CREC, one of the biggest roles that we have been asked to do under this pandemic is to really provide visibility about our communities by helping to educate the media and the mainstream communities about the needs that we've been seeing across AAPI communities, including the rise and escalation of AAPI hate and violence. We've been engaging in immediate advocacy, particularly with the new Biden administration, around making sure that there are interagency approaches to now addressing the rise in AAPI hate, including approaches that connect not just Department of Justice and Health and Human Services, but also Department of Education. And finally, that this is the moment for all of us within the API community, but also within the larger social justice and racial justice movement to call for long-term infrastructure changes. And for us, that includes our right to be seen through disaggregated data, similar to what Denny shared, our right to heal through increased access to health, but also increased access to mental health services and support. In a recent study that we did in California, we wanted to understand how Southeast Asian Americans were being impacted, or how Southeast Asian American mental health was in California. And one of our biggest findings was that over 60% of individuals who accessed mental health care actually did not continue their care because the services that they were provided were so culturally irresponsible and also not linguistically appropriate. And so we know that there is an incredible amount of work for our mental health systems to really meet the needs of our communities. And finally, really advocating for our right to family through deportation reform policies that continue to impact our communities today. And I'd say one last note on this long-term work is that personally during the pandemic, I became a first-time mom. My baby Kai is now 6 months old, and his birth brought to me a completely different shift and understanding in the work that I do and the work that we all do in our communities to really provide for the next generation. And so part of our long-term work for me is really grounded and centered in the 7th generation approach, and knowing that what we do today is going to impact that 7th generation, and for us to be very mindful about not just the immediate work at hand, but what world we are creating for the next generation. It's been such a privilege and honor to be part of this conversation and dialogue, and just want to thank NHCOA again for the opportunity.
Great, thank you so much, Kyuan, and congratulations on the new edition. And you know, so often I think that when something becomes more personal for us is when it changes our perspective. And I really appreciate all of our panelists in sharing, you know, personal stories, sharing stories that they've heard of how people have been personally impacted by COVID, by the racism, the disparity, inequity, because when it becomes personal and people hear and understand these stories is when real change can happen. So definitely thank you all for sharing those stories. And again, congratulations. And having, you know, bringing a new one into the world is definitely an eye opener. So congratulations and appreciate all that you do. So we have our next question is a question to gauge what you all think has been the biggest challenge for LGBT plus populations during the pandemic. So we have 4 answers: limited access to nutrition services, difficulty accessing a vaccine, loss of employment, or all of the above. Let's see your results. So again, a large percentage of us are falling in one bucket, and it's all of the above. All of these challenges have been experienced by all of our diverse populations. And so thank you for participating in that poll. So now we want to hear from our next speaker and our final speaker, Mr. David Vincent. And David, thank you so much for being patient. I know it's very hard to be the final speaker, and I want to thank all of our audience and our participants for staying around for this final speaker. And David is the Chief Program Officer with SAGE, where he provides vision, oversight, and leadership to all direct service programs at SAGE, including care management, housing, behavioral health, and SAGE Center programming focused on LGBTQ elders. And so with that, I'd like to introduce David Vincent. David, again, thank you for your patience.
You are welcome. Hi, everybody. I'm David Vincent. I'm the Chief Program Officer over at SAGE. And for those that may not be familiar with SAGE, SAGE is the world's oldest and largest nonprofit agency that provides programming and services to LGBT older adults, training for service providers, and advocates on behalf of the needs and rights of LGBT older people. So what do we know about LGBT older adults and their experience prior to the pandemic and during the pandemic? Many LGBT elders in general, and LGBT elders of color more specifically, are literally living at the epicenter of the COVID-19 pandemic. This is not only because of their age, but also because of their experience. Many have experienced disproportionately high levels of underlying health conditions like HIV or diabetes. They've experienced higher levels of poverty and food and housing insecurity. Many experience lower access to healthcare and engage less in supportive services. Many experience social isolation and thin support networks, and many have significant mistrust of the government and other institutions based on historical and current discrimination and mistreatment. The realities of COVID-19 pandemic have shined a light on these inequities and discriminations, particularly among the BIPOC community. Next slide, please. So these realities are daily struggles for many, and we knew we needed to take a rapid response in order to address them. We knew right from the very beginning that we needed to pivot and pivot quickly. What we didn't know was how many times we would need to pivot. So to first illustrate this first pivot, let me tell you a little bit about Sage Connect. Next slide, please. Our efforts to develop and implement Sage Connect started back in March as the pandemic was starting to spread throughout the country. Right from the very beginning, we could see that our older adults, particularly LGBT older adults, were going to be significantly impacted for all of the factors that I shared earlier. Remember, we were going into this pandemic, many were already suffering from isolation and were disconnected from family support systems and from the critical services that they so desperately needed. The reports from the front line at the very beginning weren't great, and they were getting worse every day. Many were terrified and isolated. They were worried about how they were going to get food, have their medications filled, and at the same time, we heard literally from hundreds of people who wanted to help. We were also hearing from our donors and people with long histories of volunteering for SAGE, as well as our government and corporate partners. So we pivoted and we activated a quick response. And right out of the gate, we found that we had 197 matches. As we anticipated, the calls with our participants focused on making sure that those concrete needs were being met, those food security, the medication, and then we started to address the mental and physical health concerns. When new needs were identified, we connected them to care management and to resources to make sure those needs were being met and addressed. Granted, this was super difficult because most of this was happening remotely throughout the country, and many of the agencies that provided these critical services were either shutting down or figuring out how they themselves were going to pivot their services. And connecting folks to resources became quite challenging. Our Sage Connect volunteers were critical in operationalizing in our pivot and providing these life-saving connections to so many LGBT elders. Next slide, please. As you could imagine, the needs would continue to be overwhelming during these first early months. And we knew that we needed to explore other options to make these matches faster. We were making matches through telephone calls and emails and Excel spreadsheet, but we knew that if we were going to have a significant national impact, we were going to need to bring in other partners. So with that, we needed to think outside of the box and outside of the box of our traditional partners and develop new partnerships. We developed a partnership with a tech company called Monami, and they're out of San Francisco. And they offered us the ability to automate the matching process. And we grew quickly. As of today, we have 523 matches, sorry for the typo there, in 37 states. So next slide. What we are identifying though during this process is that while concrete needs were addressed, new issues were starting to surface. Many people were starting to struggle with finances and how they were going to try to make ends meet. Next slide. So then we needed to pivot again. This time we needed to pivot again, looking at the financial challenges that many were were experienced. I like to call this phase, how do you build a plane while flying, right? So next slide. So key to this process was define, design, test, and refine. During this definition phase, it was critical for us to have a shared understanding of what our goals were, because now we were bringing on other partners outside of us. We knew that we had invited 3 amazing partners to this project, or 2 amazing partners. So we had Sage, but we also had Wells Fargo Foundation, and we brought in a new tech company called LifeSense. And we needed to dig deeper to make sure that all the pieces were there and all the people were at the table. And during the design process, we worked with LifeSense to build out the app for LGBT older people. And it was important to us that the app represented the LGBT older adult experience. As you know, there are many financial wellness apps out there. However, none of them spoke to the needs of LGBT elders. And it was important to us to get that app to speak to their needs, use the language that was free from discrimination and judgment, and also use images that they identified with and that represented their lives. We went into a beta testing phase. We engaged affiliates throughout the country. And it was important for us to make sure that we were including LGBT adults, older adults from different races and incomes and experiences to test the app. It was important. We wanted to obtain their feedback through surveys and focus groups, and we compensated them for their time, which was so incredibly critical. Took all of this feedback, applied it to the app, and had an incredibly successful launch. Within the first couple of weeks, we had over 400 people that signed up for that app. And today we have well over 800 users. Next slide, please. Our next step was figuring out how do we combine everything that we've learned and how do we design to integrate data and the data analysis into our process. So we moved to virtual program. This initially started in an emergency response and became more and more refined over the 14 months. And I like to think of this as like pivoting into the future. So in New York City, like many places throughout the country, we left work on March 13th. And by March 16th, we started delivering virtual programming. Our goal was like, let's get things up as quickly as possible. Let's not overthink this. And by the end of the week, we offered 12 virtual sessions. This week alone, we are offering over 140 sessions, 141 to be exact. So next slide. So our virtual program would be the culmination of everything that we've learned. How do we design an intentional project, an intentional innovation, an intentional intervention? We knew we wanted to grow this innovation, and we knew we would need to develop systems and quality control measures that would support this work. Right out of the gate, we knew that we needed to develop programming that people wanted and people would respond to. We listened to them, and we listened to what was happening in the community and around the country and designed programming that spoke to what was happening. We needed to develop systems, obviously, as we all moved into this virtual world, that had a reservation system. Unfortunately, we, along with many LGBT organizations throughout the country, have been victims of Zoom bombing and harassment. We need to figure out like how are we going to protect our participants. We also learned as part of our contractual agreement with funders, we needed to track participation. We needed to standardize efforts to ensure program quality that was consistent with our brand, with the Sage brand. Today, we continue to fine-tune our marketing efforts to participants through weekly email blasts and through social media channels. And as of today and tomorrow, we fully appreciate the power of this pivot. And amazingly, to date, we have offered close to 6,000 virtual sessions. So thank you so much.
Great. Thank you so much, David. I really, wow, again, so much incredible information. And so now we have one final question for you. And I know that we're definitely over our time. We have one question that's been in our Q&A box for a little while. So hopefully we can get to that one question before we actually close. But our final question to our audience is, do you think wearing a mask will be a more common practice in the future? Answer one is yes, at least in the near future, perhaps the next 5 years or so. Answer 2, no, only until we reach herd immunity. 3, only if it's required in certain places. Maybe we can go to our results now. See what people are thinking about masks, a little more mixed. 53% of you say yes, at least in the near future. 17% no, only until we reach herd immunity, and 30% only if it's required in certain places. So kind of 50-50 split in terms of yes, we need to, and we'll continue for the next 5 years or so. And the other half of you thinking no, with certain differences. So thank you again for your participation. The one question that I do have in the Q&A slot as we move to questions and answers is, could someone please talk about the impact of losing loved ones and or experiencing the stressful situation created by COVID in our home countries? Can anyone respond to that, or maybe get a couple of different responses? Maybe QN, would you want to maybe speak?
Yeah, I think this is such a hard question. And I think the reason why it's so hard is that there is that our country's mental health system is so strained and lacking for our communities that so often folks don't have the mental health, they're not able to access the resources that they need. And even when they do, it's really not culturally competent. I know for some folks on our team, we were able to increase health stipends so that folks are able to access telehealth through virtual counseling, for example. But it doesn't even like scratch the surface of the real healing that our communities really need. And I know that folks have also, it's just been so painful to mourn and to grieve in the season, especially when you can't be with family. And so I don't have a good answer for that question. Just to honor those experiences of everyone who has lost so many during this season. I think it's on us to make sure that we have a stronger mental health system and support network so that this doesn't happen again.
Thank you so much. I know it was a tough question. Rebecca, do you have any thoughts on that?
I agree. It is difficult. In Native culture, there's ceremonies and healing that can happen. And I think on a national level, acknowledging loss that the current president did was quite helpful in terms of making it okay for all of us to grieve. However we do so, and yeah, honoring all that loss, all the loss of the potential and the lives impacted has been really painful. And
it's very,
yeah,
very tough. Denny, do you have any thoughts on that question? I know it's a tough question, and
I would echo what Quinn and Rebecca have said. I mean, the only other thing I would say is, which is less about the sort of stress and emotional piece, but is that, I think we have largely in our pandemic response as a nation been rather insular and focused on improving the situation in the United States, which obviously should take precedent. But, the reality is that normal here will come faster than normal abroad in a lot of situations. And so, I was really pleased to see President Biden's, for example, him releasing at the AstraZeneca vaccine that we were not using to countries abroad, because it will take sort of a global effort to fight the pandemic, even if conditions here improve. The fact is that all of our lives will not look more normal until the situation improves globally, and the United States has a key role in playing a big part in doing that.
Great. Well, thank you all very much, and thank you for that question. I think it was really an important question as we bring this issue home, and I think what it underlies is just the commonality that we have as people of color, as minority populations, and as people throughout our country and throughout our planet, that we're all in this together, and we certainly need to address it together. And it's not going to go away until we address it together. And so I want to just thank, again, our sponsor, AARP. I want to thank all of our participants for joining us today and for staying. I apologize that we went over, but there's just so much good information, and the statistics are just blaring in terms of the inequity, the inequality that we know needs to be addressed. And working together, though, as a diverse elders coalition, we certainly can bend that arc and change, make a change. And I think that, it took a pandemic to shine a light on something that we all knew has existed for centuries, and something that we can certainly make a change, and we can do that. Just like to ask you all, if you want to follow us on Facebook or Twitter, Instagram, YouTube. This session is being recorded, will be on our YouTube channel. And in closing, again, I just want to thank all of you for joining us. I want to thank our incredible panelists. Thank you for, again, not only the data and the information, but your personal stories, and the really helping us to just really feel this national impact. And these lessons learned are things that we can take in the future to certainly make things better and a healthier planet. So again, thank you all for joining us, and we look forward to seeing you again, and hope that you will join us at our next session. Thank you.
Thank you.